comes, I'll introduce her. So,
I'm here.
Kathy has arrived.
Oh, fantastic! Great, good. So, well, welcome everybody. I'm David Pearson, the independent chair of the ICS. Actually, today I'm not going to go around everybody to get everybody to introduce themselves, because I think that takes quite a lot of time. What I'm going to do is to ask people to introduce themselves when they contribute and their role on this occasion. We've got a lot of business to get through. So welcome to this meeting of the ICS board. In terms of apologies, we've had apologies from Catherine Underwood, but Mel Barrett is here, the relatively new chief executive. I don't know whether it still feels like that, Mel, but relatively new chief executive of Nottingham City Council. You're very welcome.
Still pretty new and shiny, David. Just
yeah, excellent. Well, it's good to hear that, Mel. Thank you. And Claire Ward is representing John MacDonald due to clashes with the Derbyshire ICS board meeting. And we've got apologies from Melanie Brooks and Councillor Tony Harper, but Councillor Kevin Rostance should be on the call. And Tim Haywood is, and also from Tim Haywood, the South Notts ICP PCN representative. So thank you very much for coming. And then what I would like to do is, in terms of the welcome and introductions, I'd like to first of all welcome Kathy to her first meeting. We agreed that we do an overlap month, which has been pretty enjoyable from my point of view in terms of the conversations that we have had. Kathy, do you just want to introduce yourself, and we'll have a longer session with you later on.
Yes, thank you, and good morning, everybody, and thank you, David, for that introduction. So, for those who don't know, I'm Kathy McLean. I'm the incoming independent chair of the ICS, and as David says, we're having a sort of a very useful, actually, handover month. And as David says, we've had quite a lot of conversations, and we've got that ongoing. So I think that's really helpful. As David says, I will later on have a chance to say a bit more and some early reflections. And obviously, what I'm doing at the moment is getting round and meeting with everybody. I've already met quite a lot of people, quite a lot of you that I can see here today. And if I haven't met you yet, I will be doing. So don't worry, there's no particular order to this. It's just administratively how it's worked out. So I will be getting around, and that's been really good. And I'm really looking forward to working with you over the next while. So thank you, David. I'll leave it at that for the minute and say more later.
Thank you very much, Kathy. And Kathy and I have known each other for a number of years in various sort of bumped into each other in various roles, and I'm absolutely delighted that you're picking up the reins, Kathy, and I have no doubt that under your clear and measured leadership, with all your experience, there will be great things ahead for the Nottinghamshire ICS. So welcome. The next thing I want to do is to mark. We've got it's comings and goings this month, and one of the goings is Dr. Andy Haynes, who, as our executive lead, and I just wanted to. I don't know whether it's still a secret, Joanna, but we have arranged a bit of a collection for you, so we hope to be able to send you on your way with something that you can enjoy. But aside from that, I just wanted to say, well, we've known each other for sort of 20 years, really, I think. And in fact, I think it's quite interesting because Andy reminded me we'd actually been part of a kind of co-mentoring type group for a while across health and care. I think I was an assistant director of social services at the time, and Andy was kind of heading into the stratosphere of medical leadership. And I think it's quite interesting that we were inquisitive and inquiring enough to want to do that, actually, because at the time it probably wasn't it wasn't, integration wasn't quite where it is now. There've been various attempts, and I suppose what I wanted to say was, every now and again you meet somebody whose integrity is so deep and his commitment is so strong that you think, gosh, I'm glad I met that person. And that's how I feel about Andy. I think somebody who has done so well in his medical career, has been a medical director of Sherwood Forest, and I was around at the time when there were 6 or 7 chief executives and several turnovers of the board in a very short period of time. And when Andy became the medical director, I could feel the change as I used to step across the threshold that he made to the difference of the culture of the place. And I know that, John and Richard have done great things in taking that forward, initially with Andy and subsequently. So that in itself was a huge achievement. But also, since I took up the role of STP lead, when we're all thinking, what on earth is this and how are we going to make this work? Andy was always texting me and saying, you're doing a great job, and what about this? As well as obviously flying the flag for clinical leadership. But even in that context, he was instinctively unusual, because he absolutely was determined that this was going to be clinical leadership, not only of doctors, as important as you all are, but of allied professionals, social workers. He's got a very inclusive kind of broad set of arms that he wants to put around people in order to make things happen. And then of course moved into the role of executive lead for the ICS, and I think there are a number of things. His leadership is in some ways understated, in the sense that you don't get lots of dramatic gestures from Andy. You get nudging, evidence. He loves data. We've shared his data. He loves to make things happen for the benefit of the people that we serve, and that shines through all the time in everything he does. So I suppose the other thing I would say is that it's, as I said in the press statement, it's very unusual in my experience to find somebody who's a leader in their medical field or in their chosen specialism, has got a determination and to indulge in collective endeavour to make good things happen for the people that we serve, but also is fundamentally humble and down to earth. And that for me epitomises you, Andy. So on our behalf, thank you so much for all that you've done for us and for the people of Nottingham and Nottinghamshire.
Thank you, David. I'm very humbled by those words. I've been very privileged to serve the city of Nottinghamshire now for a few decades, and that's been amazing. And I've been very lucky to work with some amazing people, many of whom are on the call today, but others who aren't. So I feel very fortunate to have been able to use my time over the years to try and help the public and the lot for health and care in Nottingham and Nottinghamshire. So sad to leave, but I know it's in good hands. And I think with all the new changes that are coming, there's a real opportunity and actually probably a responsibility on us to move this system forward and become what I think is going to be one of the best systems in the country. All the building bricks are there, and I guess I'm challenging you now to take that up as I return back to my humble beginnings and leave health and care behind. But thank you very much. Those very kind words, much appreciated.
So, David, I wonder whether I could hijack the meeting for 2 minutes at this point, if that's acceptable.
John, for you, I'll allow it.
Thank you. It's almost as if this was scripted and planned. So, morning, everybody. I'm John Towler. I chair the governing body of the CCG, and I serve as the vice chair of the ICS board. And as David said, it is comings and goings. So it's your last ICS board meeting today, David, as our independent chair. So I just wanted to say a few words on behalf of colleagues, please. It's always difficult to go second. I think it sounds always as if you're echoing, but I'll try not to repeat too much. So you and I first met, David, in 2008 around a PCT board table when I was straight out of the public sector, somewhat prickly, I fear, very clueless about the NHS, public health, social care. But I quickly realized that you were one of the people who talked directly, who spoke very clearly, always applied a whole bunch of common sense. And therefore, I learned early on that you were one of the people to whom I should pay very close attention to what you were saying. So we fast forward 13 years, and I think very little has changed in some respects. Maybe some of the prickliness has gone. I've definitely come to accept, along with many colleagues, I think, that feeling clueless from time to time is par for the course when we work in this sphere. But more importantly, your sage words, your intelligent counsel remain entirely intact and continue to demand my attention. And I think, I hope others would agree, the attention of all of us. And then, as is very frequently the case, a new acronym came into our world, believe it or not, in December 2015, that being an STP. I think many of us initially didn't quite get it, but you've been a consistent advocate for integration and for doing things well together for as long as I've known you. So it's to your great credit that you stood up and volunteered your services and offered to work with partners across the system, lead us into a different way of working, and then to becoming one of the first ICSs in the country. It was the Super Bowl a few days ago. I'm sure people will have stayed up all night to avidly watch that. So I thought I'd just use that as a little metaphor for some of the things I think you've been able to offer us. You've consistently been our quarterback, David, confidently directing the plays. You've often played the role of coach, helping us to grasp new and confusing concepts. You've kicked many a helpful field goal on our behalf. I think on many occasions, you've been our cheerleader, hold the image, everybody, motivating and encouraging. And sometimes when it's become a little tricky, you've picked up the mantle of referee. I'm not really sure what a tight end is, but you've almost certainly demonstrated some of the positive aspects of that role too. I think there's some pushing and shoving goes on, David. I'm sure you've done some of that from time to time. So your contribution to Nottinghamshire really is immeasurable, and your influence will be missed greatly. It is a great shame that we're kind of doing this via this media this morning, and that we're not able to meet face to face today to thank you properly and to give you a gift. But Joanna assures me that something will be winging its way to you shortly. I'm sure that you'll continue to be in demand, probably both locally and from the great and the good nationally. But I do very much hope you are able to find a balance and that you can spend time in the places you love once the rules permit us to do so. So perhaps if colleagues could just unmute and join me in saying a simple thank you, that would be great. Thank you, David.
Thank you.
Thank you.
Thank you, David.
Thank you, David.
Good job, David.
Thank you.
Well, thank you very much, John, and also, can I just express admiration for you being able to hold that metaphor for the whole of the address. That was quite some feat.
Well, I'm not sure whether it was an analogy or a metaphor.
Well, so yeah. Okay, whatever. Yeah, absolutely. But thank you very much for all those kind words and for everybody's support and contribution over the years. And I'm not going to say very much, but just to say that, like Andy, I am completely confident that with people pulling together, perhaps with the frameworks that are outlined in the white paper to a degree, but with people pulling together in common cause, then this system can achieve great things in the future. And I wish you all the very best in those endeavours. So thank you very much indeed, and I'm going to move us on now. But thank you for that. So if we then move on to the minutes of the last meeting, and just to check that there are that everybody's happy with the meetings of, sorry, just check on conflicts of interest. Does anybody have any? Just check that. No. Okay. So minutes of the 21st of January ICS Board Meeting and action log. Can I first of all take the minutes and check whether anybody has any wants to correct the minutes or has any observations on them, comments? And please do use both the chat and the hand up mechanism if you wish to contribute. Okay, that's fine. And then the action log. Any updates on that or any questions on the action log?
So I'd suggest, Dave, that all 4 of those actions are part of the ongoing discussions that have been happening around the sort of system planning and prioritisation.
Yeah.
Covered in the paper in confidential board. So probably if we reframe those in the light of that discussion, that might be helpful.
Yeah. Okay. Thank you, Andy. And I noticed otherwise they're in good order in the fact that things have been done in a timely fashion, I think. Okay, and I'm going to move on rapidly then to the patient story and welcome Tom Evans. Are you with us, Tom?
David, hi. It's Alex here. I was just going to do 2 sentences before handing over to Tom and Rob, if that's okay.
Yeah. Yes, if you could just say who you are, Alex, just because it's the first time that you've spoken. Yeah.
Thanks, David. So morning, everybody. Alex Ball, Director of Communications and Engagement for the Integrated Care System. And so we obviously have a patient story every meeting. This time, because we're focusing the rest of the agenda around our people work, and please see Lynn and the team are kind of poised here to take us through that. We've done something slightly different with the patient story, so it's a much more staff and people focused kind of exploration, particularly around the vaccination programme. I think it gives us a really interesting example of how when we look beyond our borders, look beyond our kind of natural borders of the health and care system, there's a whole group of people who can contribute, want to contribute, and are able to contribute. So I think it's a zoom in on something I think is quite interesting and exciting about the vaccination programme staffing, but I think it gives us a bit of a wider lesson as well that we might want to take forward around how we can draw on different resources in all of our communities to deliver our health and care ambitions. So that's my grand introduction. I'm not sure if I'm handing to Tom or Rob to kind of kick us off. I'll stop talking now. Thank you.
Thanks, Alex. Morning, colleagues. My name is Rob Simcox, Deputy Director of HR at Sherwood. And for the last 16 weeks or so, I've had the pleasure, and it really has been a pleasure, to coordinate a workforce to support the vaccine programme, ensuring citizens of Nottingham and Nottinghamshire get access to the vaccine. Clearly, workforce people an integral component to all of this. And today's story and in the paper that you've received just epitomises that community spirit when colleagues have come together to achieve what I do feel is truly remarkable. No day is the same at the moment, but what I am immensely proud of is our ability to coordinate people en masse. This week alone, we've probably got circa 450 hold times that are supporting the programme. Paper talks a little bit about, we've had some huge interest on this scheme, over 4,000 expressions of interest. And as it stands today, we've got about 2,600 individuals that are in some shape or form contributing towards this programme. And when Alex and the team approached me a couple of weeks ago, it was about how could we capture this in something that just really sums up what we've done today as a programme. And I think it's fair to say Tom, who's one of our site managers, is here today to just capture and share how bringing people together can actually achieve some remarkable things. So, Tom, I didn't know if I'd pass over to you to perhaps just provide a bit of enlightenment of the types of support that you've had through your site, which just summarises how the programme's been working to date.
Yes, fantastic. Thank you, Rob. So my name is Thomas Evans. I'm currently the Senior Ops Manager of the Kingsmeadow Campus Vaccination Centre. And I've worked at NUH and Sherwood Forest, so I can see some people that I've worked with previously. And the nice thing about the programme is that I'm getting to work with colleagues both old and new, so I'm getting to work with a lot of people that I've worked with before across the system, which is really nice to kind of meet those people again, and some people that I've known a long time, as well as getting to work with some very new people, some of our medical students, our nursing students, but also people from non-healthcare backgrounds. And one thing that stands out to me is the dedication of our public and our communities to get involved in this programme to help drive this forwards with us and make a difference, which is a real great thing to be a part of, and I feel very privileged to be a part of it. Some of the great things that have been happening are from the Sherwood Forest end and the HR recruitment through the nurse bank there, and how they've helped to rapidly onboard people for us to help support the programme as we've gone live, and looking at how we can work flexibly across the system to work in a different way to deliver the service, and that's been working really well for us.
Thanks for that, Tom. And I think the paper that you've received also talks about how we've had all different walks of life contribute towards the programme. And clearly, what we've found over the last certainly kind of 6 weeks of this programme running at pace is that all contributions have really been appreciated, and some of that team community spirit has really been encapsulated across the variety of different locations in Nottinghamshire that we're delivering the vaccine at the moment. So I hope that provides a little bit of insight to what has been truly a remarkable kind of programme to date.
Thank you very much, both of you. That's a very interesting paper, I thought, and brought to life some of the issues that you've been working with. Would anybody like to come in and comment or ask questions on this? Claire Ward.
Thanks, David. I think that's a fantastic paper, and lovely to hear from Thomas as well about his experience. Just looking at the number of people that we've had, and from the very different walks of life, when this more acute period is over, in terms of the pressure of the vaccination centres, what's our long-term plan to see how we can bring some of those people into the health service on a more permanent basis, as a number of them may be thinking about career changes, and perhaps there's an opportunity to show them what else we'd like them to be involved in for the longer term.
Thanks for that, Claire. I think what you're describing there is a unique opportunity. That we've got a number of individuals at the moment that are connected to this programme that can clearly support some future pipelines into a variety of different opportunities across the system. One thing that I was exploring certainly towards the summer of last year is how we can operate a more collaborative approach to a bank offer at Sherwood Forest hospitals. We've been supporting care homes, we've been supporting community services, and clearly a strategy there where we can support some future pipelines, future workforce, whether that be a healthcare support worker, whether it be a training nurse associate. I think there's a variety of different opportunities that clearly make this a very unique opportunity that we need to grasp, and certainly discussions with the likes of Lynn and Andrea and Jackie that I know are on the call today. It's about how we harness that for future pipeline and future strategy.
Thank you. John Towler. By the way, John, I didn't find you prickly at all. I thought you were just keen.
Yeah, that's very kind of you to say. So thanks, David. There's been a huge amount of goodwill around the vaccination programme so far, and we should be hugely, hugely thankful for that. I wonder if, Rob, you might just say a few words around sustainability in the medium term. I think it's pretty likely that there's going to be some sort of major vaccination going on for some considerable time. And it's possible that I mean, goodwill will tend to fade over time. So if you just say a bit about our thinking about how we're going to make sure that what we do is sustainable from a workforce perspective over the next couple of years, that would be helpful, please.
Yeah, a couple of thoughts immediately come to mind, John. One is clearly well-being. So that approach, that personally centred approach to ensure that we can support individuals' well-being during the programme, which links into retention. And I think both of those come hand in hand in how we can recognise, reward, compliment, but also ensure that individuals have that personally centred approach. It's a bit of a numbers game as well, if I'm fair to say, that inevitably we've always recognised that the model that we've developed, which is a bank worker model, some individuals may want to contribute more one week than another, but trying to create that personally centred approach underpinned by a bit of community spirit, I think for me is where we start to pay dividend, and recognising that individuals then want to come back. You know, it's that cliche, if you support, if you look after, if you treat individuals with just some common principles around decency and respect, that engagement continues. And it's a cornerstone of the SFH Bank of, you know, we try and do things right. I appreciate we don't get it right every time, but little things like weekly pay are all key components around making this more of a sustainable programme. Notwithstanding all of that, we may need to do some additional recruitment at some point, just to kind of bolster that, to recognise that we've got a pipeline that meets that ongoing need and ensures that we've got appropriate colleagues to support the longevity of this.
Thank you very much. And I think there aren't... John Bruin.
Morning, everybody. Thank you, David. John Bruin, I'm Chief Executive of Nottinghamshire Healthcare and co-responsible officer for the vaccination programme. Just to say thank you to Rob and all his team for the fantastic work and effort they put into getting this together. And we'll talk a bit later about some of the performance and outputs, but it's a remarkable sort of coming together right across the system. And I think it's a really good example of the ICS working collaboratively and collectively for the greater good. And I think as the question implied, this is going to be something that will need to move from sort of an emergency planning footing to long-term business as usual. And there's already some emergent sort of thoughts about how that's going to look in the coming months and years. But despite some early challenges, that this has been a fantastic piece of work, and I think puts us in a really good place. So if Rob could pass on to his team, but also to Tom and others that are running the sites, it's fantastic to be part of. So thank you.
That's great, John. Thank you very much. And in the paper, it says one of the recommendations is to sort of raise awareness of the local vaccination programme, and I wondered if you had any observations about how that might translate into action. John, I suppose we're thinking of you, John, because you're the programme lead. I mean, I assume there's a lot going, well, I think there's a lot going on anyway. I don't assume, I know there is, but just wondered if there's anything else you'd like to add to that.
And just to develop the point about, you know, this has come from a standing start just before Christmas. We're not even at the end of February. We've either just about to achieve last night or this morning our 250,000th dose. So we're at the 250,000 point. But that's a relatively small proportion of the overall population of the county, and it's only first doses. And we know that there's going to be some additional boosters and change to the vaccines required in probably in the summer, autumn. So already we're starting to consider how we move this to business as usual. Because NHS is fairly adept at regular vaccinations, immunisations, as people know, and it's the mechanics of how we get from where we are now that will be the important rush to to cover the most vulnerable to getting it into a steady state, and we're starting to work that out.
Okay, thank you. And Amanda, and then we'll wrap this up.
Thank you, David. Now, just to say, I've had the really good fortune to go to some of the sites, and the talent I think that's there in leading the sites is really tangible, and the way that very quickly the processes have got set up in the sites and been refined on a really sort of quick learning basis is really impressive. And also just to say the sense of community was incredible as well, with volunteers, just a real sense. And I think the healthcare workers really liked the fact that people are really grateful, and it's a real kind of milestone for a lot of people having their vaccine. So just to say there's a real buzz about the place, and the talent, the leadership talent there is really, really tangible. Thank you.
Thank you, Amanda. And the programme clearly gets a resounding round
of sorry,
for the dog in the background.
Sorry, really bad timing.
No, I think it's an important contribution. So that's brilliant. I think in relation. So thank you very much, Rob and Tim. That was fantastic, and it's obviously a crucial contribution at this particular time, and we're very pleased to receive your presentation and the report. My observation about the comms and the process is that everybody's absolutely right to think that this is part of a continuing process, not only to vaccinate the rest of the population, but the vaccination programme in the autumn, and then there's flu as well. So keeping under review what's gone well, what hasn't gone well, and what could one do to make this business as usual, and having a run at these things is critically important, both nationally and locally. And the way that we just declare that I am on the National Programme Board, and Emily Lawson continually says that the confidence of the people in the programme is critical for people's being confident about taking it up and making themselves and the communities safe. So the way that we do things in this context, and the commitment we show is a critical feature of that, and is alongside all the massive logistics and deployment and organising things which also is important, but that the method and the way that we do things is as ever critically important. So I assume therefore from this conversation that in terms of the action, that action around raising awareness will be taken into account as the programme moves forward locally under John's leadership. So okay, we'll move on, and then it's quite we're moving rapidly on to the COVID-19 response, and I think, although it says Andy, I think it's somebody else beginning with A. It's Amanda.
Yeah, that's right then.
Thank you, David. Yeah, I think there's just some slides coming up. Thank you. Lovely. Yeah, next slide, please. So just wanted to highlight to the board a number of things around the overall position around COVID as we currently stand. So the good news is that the level of hospital admissions is starting to come down, but we do still have more than double the numbers of people in hospital than we did in the first wave. So despite the really excellent news we've just heard around the vaccine programme, it's really important still that people do follow the social distancing requirements, and we do need to get the community infection levels lower than they currently are. And I think although sort of very recent data suggests we are really starting to turn a corner now, the rate of admission reduction has been comparatively slow compared with other parts of the country. So that does mean that our rates per 100,000 are higher than the national average at 234.6 rather than the national average of 142 per 100,000. And you can see here some of the scale of the admissions that we are still seeing. So in the week up to the 7th of February, we saw 352 admissions. compared to 342. So it's a sort of some weeks it's sort of fairly steady, and then it drops a little bit, but the overall trend is definitely down. And still over 600 people in our beds as well across our hospitals. So again, that is more than double what we saw in the first wave, and 12% mechanically ventilated. So both of, in fact, all three of the sites where we have got critical care services are still running at their highest alert level. So it's a very pressured position still, and we are still really needing to get the infection rates down further. Deaths, unfortunately, are continuing to be high, sadly. You'll see here, though, as John alluded to, actually, and we now really are covering a really good proportion of our total population, and you can see here on the latest published data that for the top 4 cohorts, we're making really good progress, and we had achieved over 50,000 vaccinations in that most recent week up to the published data. Also, just to mention other parts of the system outside of the hospitals, because it all runs very much as one system, and the flows of people in and out of the hospital. We do have staff absence of around 8% still across the whole system, and we are still seeing a considerable level of activity in general practice, as you would expect. Approximately 500,000 consultations a month, and over half of those are face-to-face. Thank you. Next slide. Just thought it was worth putting this in to show how closely aligned the hospital admissions are with our community transmission rates. You can see there is a bit of a lag time there. It's not an exactly to scale, but also just to show the very steep curve in October, which was largely in a younger population initially, did before long track into our community and our admission rates. And you can see that there's been sustained levels of significant numbers of people in hospital for a long period of time. So clearly that will have a bearing on the workforce. Next slide, please. So with that in mind, I just wanted to highlight a few issues to the board, really. One is to note the immense professionalism that there has been through what has been a very sustained response and period of time. Some people are tired in areas, and some people have, been quite traumatized by some of the events that they have witnessed. And so workforce resilience is very, very aligned to the agenda today, but that is a really critical area. And then I think the other thing to say is that there is a balance. There's the system pressures about keeping COVID and non-COVID sort of health services running as well as possible, but very, very strong interlinks with the care services, who also are working under very significant pressure over a very significant period of time. And it really is testing the resilience. And it's only through that absolute combined effort across the whole health and care system that we're able to keep services safe and running. So I think all colleagues across all areas have been working incredibly hard and making really good efforts to keep that flow going through the hospitals and through our community mental health services as well. Really important. And I do think there's some benefits there. I think, as we saw in the earlier example, I think there has been an accelerating of some of the multi-agency working and some of the partnerships and more flexible approaches to how people work, which is great. And we need to make sure that we embed that and capitalise on it as we come out the other side of COVID. Thank you. So that's my summary for the board, David.
Thank you, Amanda. That was very helpful and very clear. Thank you very much indeed. We did have a reasonably substantial conversation about this area last time, and I know that there are mechanisms of communication across the various programs into organisations, but if there are any quick questions, happy to take them. My observation in saying that is that twice this morning we've mentioned, people have said, actually this actually tells us something about system working and how we can work well together, and it accelerates that. And it seems to me capturing the ingredients of that in real time, promulgating them and communicating about them is the way in which we stop people needing to reinvent the wheel in a way, and also reinforces good things. So this is a really demanding time in healthcare and local government and wider public services. It could not be more demanding, really, and it's sustained over a long period of time. That's the issue. So as well as looking after one another in all levels, in all organisations, it also is important, I think, to pull out those things of good practice and share them, promulgate them, because it encourages everybody, in what is the face of considerable challenges on a daily basis, no doubt. Tracy Taylor.
Hi, David. I'm Tracy Taylor, Chief Exec of NUH. I just wanted to echo that, David, because I think right from the beginning, before we had wave one, the infrastructure that we put together in terms of the cells and the chief execs having oversight of the process of COVID all the way through last year and now in the vaccination programme has really demonstrated that as a system, when we coalesce around something and actually focus on the outcomes of that endeavour, we do a fantastic job. And I think it was Andy that said we have the ingredients to be a really good system, and I agree with him, because what we've demonstrated over the last year through what has been the most horrendous challenging period has been more bringing us together and being able to demonstrate delivery on things that I think that we probably have not done in that way before. So I absolutely agree with you that we do need to learn from that, and we've done, as chief execs, we've started to look at what that is. But I do think that it is the start of a process and a way of working that could work for this system exceptionally well.
Thank you very much, Tracy. Richard Mitchell.
Morning all, Richard. I'm the Chief Exec at Sherwood Forest Hospitals. So yeah, just building on what's been said in the conversation we had at the last public board a month ago. So clearly many things have gone well. I think there's also the recognition that the challenges we face over the next 12 months may be at least as difficult as the period that we've been through. I think to an extent across care and health, inevitably, we've focused on our COVID services and our COVID patients, and we need to find a way collectively over the next 12 months to find a balance between restarting, strengthening the many services that we need to be doing, whilst also recognising that the best way to do that is truly focusing on the needs of people who work across all of our organisations. So a way of supporting people with their individual welfare and wellbeing needs, enabling them to decompress individually, have proper rest, I believe is the best way in which we can reinvigorate our services in the way that we need to do for months and years to come.
Thank you, Richard. Adele Williams.
Thank you. Yeah, and huge thanks to everyone involved in the vaccination programme so far. And I know it's been extremely well run on the ground in the vaccination centres. My mum, I'm from Mansfield. My mum's just had hers in Mansfield, and many of my council colleagues have been sharing online what a positive experience it was. So it's a real testament to how well we can work as a system in bringing those things together. Just wanted to ask a question about the the emerging understanding of sorry, my cat's about to join us. The emerging understanding of the sort of multiple factors around the impacts of COVID on particular segments of our population, and how we will be reacting to that as a system. So we know that it's really important that we get the vaccine to areas of high deprivation and all of the other factors that play into that. I'm sure we'll pick this up in the private section, but I just wanted to flag that there is, it appears that new directives are coming from government around that, and how we're planning to respond to that. Thank you.
Okay, I'm going to ask Amanda to pick up that quickly in a minute, but I'll just say that the government published its uptake strategy over last weekend, and on social care, I led a piece of work on this with Nikki Kanani, and we've written out yesterday with a set of materials, so it's linked to the uptake strategy, wearing my other hat. So I think once you get through the different cohorts, there's a lot of work that needs to take place to make sure that people don't get left behind. And it's not like you move from one cohort to another and then the last cohort is forgotten. It's a continuous process. But I'll just ask Amanda if she wants to say anything else on that.
Yes, thank you. It is really important, and I think the pandemic has sort of unfortunately laid quite bare, hasn't it, some of the inequalities and made them worse in some ways. So the way that we're approaching that, and again, I'm sure we will talk in more detail, partly it's driven by data. So we're now able to see which areas have got lower uptake, and we're working very closely with the GPs and PCNs, starting with a targeted approach around texting, but also ringing individuals as well, re-inviting and prompting around invites to go to the vaccinations, also taking the vaccinations out, doing more of an outreach as we've kind of developed the operating models, a bit more flexibility around numbers of venues with the AstraZeneca vaccine that we can do that. So more outreach, which is starting to really increase actually into different venues, but also actually learning from some other areas as well, actually visiting people and sort of talking it through, because it might be just that people haven't picked up messages. It might be not that they're vaccine reluctant. It might just be that they haven't quite engaged with the programme for a whole variety of reasons. So we're using a number of different means to try and give people every opportunity to attend. And we're also very grateful for council colleagues who have sort of helped with the ringing round, but also supporting. Eunice's video, for example, was really excellent in terms of giving the message as community leaders to say, look, it's have the vaccine, it's a good thing to do. So I think it's the combination of all of those things. Thank you, David.
Thank you. I've still got hands up for John and Tracy. Do you need to come in at this point?
Just very briefly, because I think it's a really important point Adele raises, and to follow on from Amanda's more immediate things that we're doing, that there's been a massive, I think, wake-up call for NHS and social care around revisiting the health inequalities. So much of the variance is driven by the wider social determinants issue. We've got a really good setup around our health inequalities plan, but people may not be aware, there's a regional STAR board that's got 4 priority programmes, one of which is health inequalities, and it's got some really good representation from across the region, from both health and local authority inputs in driving how we can really mobilise the shift in the dial to focus more on prevention, population health management, targeting vulnerable groups. And I think there's a critical energy now behind that to do some quite significant transformation change. In the longer term, I think that will start to have some of the impacts that we're working towards. Thank you, David.
Thank you, John. And finally, from Kathy McLean.
Yes, thank you. I mean, it's a fantastic programme of vaccination, and also, on Amanda's presentation, good to see that the numbers of patients and so on are coming down. 2 things for me on the vaccination, just appertaining to the conversation we've just been having about the differences between different groups, I'd be keen to understand what's our ambition in terms of closing the gap, so that, you know, how close are we aiming for, and what's our assurance that we will get there? How assured are we that we will do that?
Okay, thank you. Amanda, do you want to quickly address that? And I suspect there are things for further iteration actually outside the meeting. It could be actions that we pick up and put on the action list from this item. So just very briefly.
Yes, thank you. No, our ambition is to get the uptake rates in terms of immediacy. I think the ambition is to get the uptake rates really, you know, right up into the high 90s for all groups, and so there's very targeted work for that. And I think some of those longer term ambitions we'll need to work through with John, and the sort of think about our outcomes framework and how far we want to push the sort of dials in terms of those as well. But we are very ambitious around the vaccination programme, and we would want to see the same uptake rates in all of our groups.
Okay, thank you. And thank you to, so there's two dimensions to that conversation. One was the bit about learning and the good work that's taken place. And thank you, Eric Morton, for your comments in the chat, which I think summarised that issue really well. And then the second issue was about the ambition, the future, some of the challenges that need to be addressed out of this. And I think therefore the key actions out of this are to continue to share that best practice across the system, expose it and understand the ingredients of it. And the second is, so what's the next bit of ambition, as Cathy described, and perhaps continue to articulate this both in the programme and back at the board. So that's very helpful. Thank you. So we're now going to go rapidly on to introduce the item on the People and Culture Board. Lynn and colleagues, and I think we might have Emma Challens, Director of Culture and Improvement, Sherwood Forest, Helen Mancini, Associate Director of Learning Organisational Development at NUH, Andrea Brown, Associate Director of Strategic Planning and Workforce at Nottinghamshire CCG, Jacket Hewlett Davis, Workforce Transformation Lead, and Sonali Kinra, our Interim Clinical Associate with the Nottinghamshire CCG, and Ricardo Pereira, Associate Director of Transformation, Nottingham University Hospital. So we've got a powerful team here, Lynn, to support you.
We've got a huge team, and thank you. We don't need to introduce ourselves now, David. So
well, I thought I'd just do it for you since I've got the list here.
That's brilliant. Morning, everybody. I'm Lynn Bacon. I'm Chief Exec of City Care, and I'm also the SRO for People and Culture for our system. And I do really want to start off by saying a big thank you to colleagues who are joining me. They work tirelessly. They are absolutely brilliant and a privilege to work with. So I'm going to try and get a whiz on and ask Andrea to put up the slides, but in the meantime I want to set out why we're here, what is it we're talking to the board about. And there are two key elements of this really. The first is to update the board and confirm our position against the NHS People Plan 2021 and some of those key priorities. One of them we talked about at the last board meeting, which is a huge priority across the country on the well-being of our staff. For this particular presentation, we're going to be focusing on three other key priorities, one being about recruiting and retaining our staff. The other one is about equality, diversity and inclusion. We're going to have a specific focus on racial equality, which has been really at the forefront for our staff during COVID. And the third thing is the leadership and culture, which is that golden thread that runs through all of this. The second element of why we're presenting here is to really highlight to the board that we are rapidly approaching real changes in the governance, oversight, assurances required at system level around the people and culture agenda. You'll see some of that coming through the white paper, the changes to HEE, but in effect, systems will have clear let me just go back a bit. A workforce operating model is under development, which clarifies responsibility of systems, responsibility of organisations, and it is going to require us as a board and as a whole system to look at this agenda very differently and get prepared to be on the front foot of the changes that are going to happen. And I want to just run through very briefly what some of those changes are. So at system level, to agree and set out clear workforce roles, responsibilities and accountabilities across the partnership. In order for us to ramp this up, we need to we will be highlighting that we need consistent and protected capacity resource to be able to do this effectively and identify roles. And I think my leaving will be an opportunity to relook at this, but it is something we need to put in place fairly quickly. The second thing is about embedding workforce planning into system planning across all partners. We've made really good strides on this in terms of NHS organisations. Our September workforce plan was more inclusive, and it is something that, yes, we've got a really good baseline. We're starting to really improve on this, but we need to get to the point where it is business as usual, and we've got the right level of data that helps to inform our planning to be much more effective. The next one is about facilitating a shared understanding of the operating model among stakeholders. Well, we're starting that today, so we're informing you it's coming, and this narrative will frame part of it, and then we'll need to come back and be really clear about what it means in detail when it's there. Proactively prepare the system and people culture governance functions to deliver the expectations of this enhanced role. Some of that enhanced role is about devolved funding from HEE and how systems coordinate the learning development funding at a system level. And then finally, ensure the ICS board has greater visibility of the people and culture challenges, risks and planned mitigations from performance and assurance perspective. And actually we're quite limited on that at the moment. And so I will come back at the end of the presentation to go through some of the recommendations to help us with this. So if I can have the next slide, please. Are we able to move it on, Andrea?
Apologies, I'm having some technical problem here with my two screens, so I'll try and get it.
Okay, so maybe if you're struggling, I don't know whether Joanna or the team can help, but the first slide that will appear is for information, because I'm conscious that we've got Kathy who's joined us, we've got people who might not have seen this work before, is really just showing you our plan on a page. This is our system plan in response to the NHS plan, and underneath that we've got a broader plan available. The second slide shows you our system governance for people and culture, and it shows how we link in with the wider recovery cell, capacity cell, the different work streams that cover our medical workforce, nursing, AHPs. I'm sorry, it's really strange that I can't see it. And the third slide, I think when we do get them up, we'll show you that what we've got is the whole regional infrastructure and oversight, that when we look at work streams and we look at workforce as being a work stream for our system, I think it's really important that the board understands that around our system, we have the Regional People Board, which I represent this board at, which feeds in nationally, and around it is a whole range of different groups that oversee and will be consistently trying to get that assurance across all people and culture boards.
Yeah, we could, if you're concerned, Lynn, we can all see the presentation because we've got it. So if you can't get it up, just keep going through it.
All right, you can see it. I'm sorry. Yeah. Okay,
yeah. Well, we can see. We've got it in the papers. That's what I mean. Yeah.
Okay.
Yeah.
We're here. Okay. So if we just flip on to the. We do need to rationalise our governance. We are having a maturity review of our People and Culture Board in March, and so we will be reviewing it. So if I can, that's
flipping around.
Technology. Okay, this is the regional. No, it's not. I'm going to move on. You've all got it. So I'm now going to hand over to Claire.
Hi, thanks Lynn. Morning everybody. I'm Claire Teeney. I'm Director of People at Sherwood Forest Hospitals and also at Nottinghamshire Healthcare. Good morning. I'll pick out a couple of things. So what Lynn had described in the first part of her introduction was the fact that we've got an ICS People and Culture strategy that was signed off in 2019, and we've been working since that time on delivering that strategy. Following that came the NHS People Plan last year, and the People Plan identified a number of things for us to complete at a local level across the ICS system. And specifically, it identified a number of actions for us to complete by the end of March this year. There were 25 in total, and in terms of doing an assessment of where we are, we believe that 8 of those are complete. And the reason that we can say that they're complete is that because they are much easier to measure and kind of review. An example of those kind of actions is, for example, the risk assessment process that we were asked to undertake. So particularly in the NHS provider organisations, we were asked to undertake risk assessments for all of our staff and our BME members of colleagues in particular, and we could evidence that we did that, and that was one of the People Plan actions. Within the People Plan actions, there are a number that we would rate as amber, and the reason that we believe that they are amber is because we can show that there is considerable work that is underway. However, this work is more developmental, so it doesn't start and stop. We think it's work that's underway and grows and continues. And I'll just take the opportunity probably to highlight a couple of things that we have been working on and possibly just talk to you about some of the impact that we think that's had. So you've heard this morning from Rob, who talked a little bit about the Sherwood Forest Bank in relation specifically to the vaccination programme. I think what's important to understand is that the Sherwood Forest Bank was something that we'd already started to develop as part of a system collaborative bank, whereby colleagues could join with the opportunity to work in a number of different settings, doing a number of different jobs across the Nottinghamshire ICS. And the reason that we wanted to develop the bank was because we got increasing feedback that people want to be able to work flexibly. They want to be able to choose the hours in which they work. They want to be able to choose the settings, and they want to be able to choose much more broadly the jobs that they undertake. The bank also provides an opportunity for people to work who've got caring responsibilities. So the concept was there around the bank arrangements, and it predated some of the vaccination programme, although as Rob described, it stood us in really good stead to be able to mobilise the onboarding of significant numbers of people to support the vaccination programme at relatively short notice. In terms of moving that forward, we see the bank as something that will support us. You asked some questions about how do we make things sustainable. We see the development of that bank model as something that will improve the sustainability of a flexible workforce across Nottinghamshire. And it also supports the national direction of travel around having a reservist model for the NHS and care in terms of being able to deploy increased numbers of people to support services at particular times of pressure. So for kind of business reasons, employment reasons, and supporting our local community reasons, we see the BAMP model as something that we really want to build on. And it's just a good example of a recruitment and retention strategy across the ICS that we have in place and are rolling out well. I should say that model that we've got for the system has also been recognised at a broader regional level, and we have received some investment to support the development of that programme of work, and it is being looked at, and we're kind of working on it as a bit of a broader case study to take the learning and share with wider regional partners in terms of that particular piece. The other thing that I would just say about recruitment and retention and thinking about how we fill some of our gaps is that We do work with our partner organisations, particularly our local universities and colleges, to ensure that we've got the right education programmes to support people in terms of their development, building our capabilities, and both attracting people to come to Nottinghamshire and also enable people that already live here to be able to stay and develop the careers that they want to. And an example of that was the Trainee Nurse Associate programme that we developed in conjunction, particularly with Nottingham Trent University, and it required all local partners to participate in that to enable people to fulfil the requirements of that programme. All of the things said about the work that we're doing around recruitment and retention, it's something that we still do need to do more around. Our turnover is down overall. We have got targets around healthcare support workers to meet by the end of March, and whilst we're well on course to do that, we've still got some vacancies in that domain that we do need to make sure that we recruit to and fill. And whilst turnover's down, we've managed to recruit increasing numbers of people to vacancies that we have. We've still got some gaps around some of the professional specialist posts, and we've still got gaps in some of the care settings. So we do still need to focus on that particular programme of work. A couple of final points for me. If you can move on a couple of slides, please, because I've moved through those things. Next slide. This is the final slide. Back one. Thanks. We've talked again, and I've heard you reference around health and wellbeing for colleagues. There's years of research and we've had feedback from repeated staff surveys about the importance of paying attention to the health and wellbeing of our colleagues that work in our services. We've seen that come to the forefront in the last 12 months with regards to the pandemic and some of the impact that's had. And we're going to need to pay attention to that over the coming period as well. We've done quite a lot of work to support staff locally, and we tried to ensure that there was consistent support for all of our colleagues working in health and care. So an example was that the health support that was in place for colleagues in some of the NHS trusts was rolled out to support colleagues in care homes. Our occupational health services have had a real impact, and I think what it's brought to the fore is the fact that we do need to invest and resource properly our occupational health services to support all of our health and care staff across the system. And importantly, pay attention to some extended psychological support. So we have introduced an initiative around rapid access for health and care staff who are experiencing extreme mental health distress, so that they can access the right support in terms of that. And we have just received some funding, 18 months worth of funding, just over 200,000 to be able to set up the Health and Wellbeing Hub for colleagues to be able to access support across Nottinghamshire, and that will launch next month. Final point from me before I hand over is just to mention the Care for Nots Academy. This is our apprenticeship and work placement academy, which had a soft launch at the end of last month. And that really is something that I do believe collectively we've really got to nurture and grow. It provides a one-stop shop for all people seeking to enter health and care settings by way of an apprenticeship, work experience and other routes. And we're currently doing some work with the Prince's Trust nationally, as part of a programme to develop the academy. So I'll finish there. Lots going on, but I think it's important that we remember there's still lots to do. And if I can hand over to Sonali and Emma.
Thank you. Thank you for that, Claire. So hi everyone. If we can move on to the next slide, please. So hi everyone, I'm Emma Challens. I'm Director of Culture and Improvement at Sherwood Forest Hospitals. Sonali and I just want to take a few moments of your time just to provide an update with regards racial equality and inclusion, and also further in terms of our EDI initiatives and what we've done as a system. So first of all, just wanted to recognise that there are currently in place quite a number of cultural indicators that we use as providers. Some are quite focused from an NHS provider perspective, but there are similar also relevant from a social care perspective. And some of those relate to things like the workforce race equality standards, disability equality standards, things they've already referenced around undertaking risk assessments, and also with regards to diversity of our leadership across our health and care system. So there are already some key metrics there and aspirations for us that we have been working towards. And one thing I think that is a real positive for us as a health and care system, as many of these are quite NHS provider focused, there's also a pilot taking place in Nottinghamshire County Council with regards to introduction of a RES, which will be very similar to that of what NHS providers use. And I think that's a real step forward for us and will add value as a health and care system. So that's something that we're quite excited that actually to be involved in and work collaboratively on. So that's just giving a picture really of some of the indicators that demonstrates our effectiveness and how inclusive we are as a system. Have the next slide, please. Thank you. So what have we done as a system? And particularly, I think, recognising over the last 12 months, even with the challenges of COVID, I think it's fair to say we have made some real headway, and we've continued to work together on the important issues, whether they were existing issues or whether they were new relating to COVID. So we've worked as a system with regards to Stepping Up programme, which is about increasing opportunities around diversity of leadership across our health and care partnership, and that's been offering targeted specific programmes to colleagues. We've also done some quite joint collaborative celebratory events such as Black History, LGBT+, and we've really worked together in terms of planning those, but also socialising those across our health and care workforce. We've also taken forward some work around diversity and in terms of our AHP workforce as a system. And again, this is about strengthening our leadership, opening up opportunities and having a much more inclusive, diverse professional workforce. In addition to that, we've already been doing quite a lot of joint work around some of those cultural indicators that I already referenced, and that is by specific groups and networks such as the BAME networks, LGBT+ networks, coming together to actually identify where are we, what can we do, and what are the opportunities where we can work together to improve on that. So we have already got quite a lot of the networks linking up with each other, and I would say that's quite in an informal way at the moment, but I think it gives us a platform to really formalise that going forward. We through the work that we have been doing there, we've also put forward a proposal for an EDI partnership advisory group, and Sonali is going to share a little bit more about that and how that links specifically to racial equality and inclusion partnership. And I think also last listed there is the symposium that we held last year, which I think, you know, was an incredible opportunity for us as a system to really truly bring health and care colleagues together in a safe space, to have conversations, to share what's good about our system, what's not so good, and what are the important things that we need to tackle together as a system to increase our diversity across our health and care workforce and broader. And below there is just some of the things that we listed that came out of that symposium that we have taken and ensured are in our action plans going forward. So that's just some of the things that we have done. The next slide, please. And I'm just going to hand over to Sonali, because I think it's just fair to say we've still got a long way to go. And Sonali will just share a little bit more about what that might mean and how that might look like. Thank you.
Thank you for that, Emma. My name is Sonali Kindra, and I'm a GP retention lead for the Nottinghamshire Integrated Care System and a clinical associate within the primary care team at NHS England and Improvement. Inequalities anywhere is a threat to equality everywhere. ethnic discrimination continues to remain the most common form of discrimination. But furthermore, if you're a female from an Afro-Caribbean descent with a disability, the likelihood of you facing discrimination is even higher. We have a long way to go, as Emma said, but we've made a start. We've held a listening event, and we are now in the process of setting up Black, Asian, and ethnic minority staff networks across our health and care system. These staff networks, their role is going to be to raise awareness amongst colleagues. It's going to be providing a supportive, welcoming voice, and also a collective voice to hold the system to account. But the heavy lifting of rooting out discrimination won't just be the responsibility of these staff networks. And that's where we need commitment from those in leadership position. Commitment of time and funding, commitment of setting the tone and leading by example by those around this virtual table, as well as those middle grade managers who make decisions around recruitment, disciplinary procedures, and career progression. A commitment to break down those so-called structural barriers which are being held up by individuals and being more discriminatory towards some more than others. Can I have the next slide, please? Thank you. As I said about these local staff networks, they're going to be across the health and care system, and they are in varying stages of maturity. Some have already formed and appointed leads, while others are just taking shape. The lead role of these networks need to be recognized and to be adequately funded, and have ongoing conversation with the leadership team. The leads of these networks will come together as an ICS Racial Equality and Inclusion Steering Group. While Emma said that we've been going through the informal stage of working together, we've already identified cross-cutting themes across these organizations. And if I give you a few examples, such as the disproportionate disciplinary reporting of the diverse ethnic workforce to the professional regulatory bodies, the glass ceiling and the barriers to career progression, and the senior leadership, which is not always fully representative of the diversity of the workforce. Can I have the next slide, please? These staff networks will work alongside the EDI Advisory Partnership Group, while also linking closely with the regional and the national networks. This is as much about influencing horizontally and vertically as it is about creating equal opportunities. I have been lucky to have the trust of some people on this board to have an opportunity to be able to prove my abilities, but it shouldn't be luck or the color of my skin that should determine which side of the table I should be on. Diversity is a strategy, inclusion is a goal, but belonging is a feeling. And a workforce that gets this feeling of belonging are 6 times more likely to be engaged and also positively impact our population health outcomes. So our intention is to give that environment of belonging for the workforce across Nottingham Health and Care System. And I'll now pass on to Helen. Thank you.
Oh, hi, sorry, so it would be myself, Ricardo, just to enter the next one. Would you mind putting to the next slide, please? Hi, I'm Ricardo Pereira. I'm the Associate Director of Transformation at NUH. I'm also speaking on behalf of the CUSA Collaborative in terms of the improvement agenda within the patch. Obviously, I'm just going to take you through, myself and Helen will take you through a bit of an update on culture change in reference to the plan on the page for the ICS. If you could pass to the next slide, please. Really what we're going to do, we'll just give you a current position update. So since the formation of the AD Collaborative and the intervening period, including the most recent response to COVID, there's been a lot of effort and initiatives undertaken over that time. From the leadership side, we've undertaken quite a lot of focused development through the AD Collaborative on what leadership training offers are. We've listed them out, though I won't go into much detail. There is the ICS local Mary Seacole programs. We've held the first cohort, which is under evaluation, just recently closed for 38 senior leaders across the patch. There's a number of development programs locally in organizations. So we've kind of expedited a mapping exercise to understand what that all looks like in its round and how we can align and share from all the different provider organizations, all the organizations in the partnership, as well as all the NHS provider organizations have also undertaken the NHSI Culture and Leadership Program in the period. So there's been a lot of leadership programs of work undertaken are taken to date, with quite a lot of people being accessing and being exposed to a lot of what's on offer across the patch or nationally. Similar veins, so since inception, we introduced the CUSA program, so that's a College Service Improvement Redesign, which is the NHSEI nationally run program from the mixed methods team. That since its inception, we've actually been able to deliver both, through a mixed economy of local delivery through provider organisations that make up the CUSA Collaborative, which is largely made up of the NHS care providers, so Sherwood Forest, NUH, City Care, and not Healthcare. But we've actually given access, or 4,000 plus staff have accessed training to date over the patch at the entry level. So that's your bronze level, your fundamentals level of training. We've also had about 209, after you account for attrition and leavers, who have accessed the advanced 5-day training within the patch, and are spread right across the provider organizations. We've also launched, in collaboration with the national team, a virtual offer since August last year. So we've had well over 200 staff access it despite all the pressures, with really good feedback on sort of the virtual offer, which is replacing what was fundamentally a face-to-face offer exclusively. In addition, over the time, we've also had trained up around 26 carers and patients, reps in QI training and QI methodologies, so how to engage with and support improvement initiatives. We have commenced sort of a mapping exercise across the improvement communities to understand sort of our improvement approaches across all the different organisations within the patch. And where that's important is leading into the second bit. So myself and Helen, could you move to the next slide, please? Really, this is around the sort of national direction of travel and some of the conversations that have been happening with the Improvement Directorate at NHSEI and the People Directorate, which is around a closer alignment of the two agendas, really. And they are sort of the two sides of the same coin. You can't really deliver the improvement without the culture change required. And similarly, giving the reason to believe so that the culture change can happen is around delivering the improvement initiative. So there is an active push nationally to move in that direction and closer align the two agendas so that there is sort of one seamless offer. Obviously, within the system here, we've had the Culture and Leadership Evaluation Programme that we've been part of, a number of providers. So there's 88 health providers in total, and the national view is to look at that at an ICP and ICS level. So they really want to develop a blueprint for how you do this at scale, at a system level, rather than a provider-focused lens. Also, there's a push to really move on with the quality with the CUSA program nationally, and how can we learn from the COVID response and the flexibility of that, but actually how does it become more inclusive and expansive beyond kind of the health focus that it's had to date. We also attended the Improvement Directors Network, which sort of drew out some of the thinking around for an ICS or for our purposes. I think we've got a lot of the infrastructure and we are quite well ahead of the game as an ICS in the context of these component parts, and particularly in the improvement space. But what we recognize in that trying to elicit a culture for continuous improvement, we would like to sort of explore what our collective vision for a system is for the culture for improvement, to include OD and quality improvement. Our collaboration needs to be more inclusive. So, though the offer was open and it was established, I think over time what we have is quite a health-focused quality improvement offer that we need to expand out, and we'd like to really start the establishment of a community of practice shared governance model, which Helen will touch on. The other thing that we've noticed in terms of the practicalities of training and delivering improvement to staff and getting them understanding of improvement practice and science, it's quite evident that from our local working, our actual practical delivery of improvement initiatives, that kind of consistency and coherence of how we go about these things, and we can talk about this cross boundaries, is quite an important part of where we need to move to. And then the strategic alignment is another lens that we've looked at, which suggests what we need to understand is how all that improvement and enabled improvement resource is aligned to the strategic objectives, the transformational outcomes of the system we'd like to achieve. So we have that in some places, but there's not a consistent approach to it. So some of those 4 areas of real thinking around where we go to next, and I think that leads us nicely into Helen and talking about what next really to help drive that agenda forward. I'll pass over to Helen.
The next slide. Thank you. Thank you, everyone. So I'm Helen Mancini. I'm the Assistant Director for Learning and Organisational Development at NUH and currently the Chair of the OD Collaborative. I would like to just start to build on Ricardo's talked about us starting to do some of that work around looking at how we do more of a check across the system around the OD offer and leadership offer, and also the improvement offer. We'd started already to do that work. However, what we realise is it's a very, very big piece of work to look at the culture and leadership offer and improvement across all of the partner organisations. We've been really very lucky. We've been in touch with our colleagues at Region for NHS E&I and explained our vision in terms of looking at that real true partnership across our system, a true collaboration and a community of practice where all equal partners contributing the best practice from their organisations around improvement and culture. It's a very big piece of work and not been done nationally at this point. Region were very, very keen, so they've now supported us with some additional funds of just under 50k to do that work independently through the University of West England. Now that work's literally starting now until the end of April, and they will be doing 2 phases of the work. One part of the work is looking at that international and national best practice around culture, leadership, improvement, and absolutely, like Sonali and Claire have talked about, the EDI and also the talent work across our system. So they're going to do that desktop exercise for us. And then the next part of the programme is they'll be coming out to talk to system partners, yourselves included, and at ICS, ICP and PCN level as well. They will also be then bringing all of that information and data together through a framework of consideration that we will bring back to the board, almost as a national blueprint. Like Ricardo mentioned, NHS improvement around the national culture and leadership work. The next steps was to look at ICP and ICS as part of their evaluation. So this will help set a almost initial blueprint, pre-diagnostic for us. It will then go on to help inform the ICS leadership programme going forward, that content, making sure that it's completely inclusive of all partners, taking the best from each of those organisations. Andy, David and Tracy, you've all said we've got the ingredients of a great system, and it's pulling those ingredients together and putting them into a framework that we take forward to inform that culture and leadership. And equally around that quality improvement. Now, since we put these slides together, there's been some further iteration of this process. So last week, Emma Challens, myself, Andy Haynes, Rebecca Larder, and the regional director for NHSI met with the Director of Culture and Leadership, the national director, regarding those next steps, because clearly after April, we want to be able to move this forward. And they have signed, and I believe Amanda Sullivan signed off the Memorandum of Understanding to actually become a pilot site for the National Culture and Leadership Programme, Collective System Programme. So it's really exciting news, and they've again offered us another £50,000 to take that work forward. And again, because it's very much in its infancy, we'll be relying on our colleagues across the system to help inform that programme going forwad. So very exciting news. So I'm going to hand over to Lynn now.
Yeah, I'm really sorry, everybody. We were absolutely out of time, and you can see the scale of work that's happening. These are the priority areas. So really, I think there's been some challenge here to the board. I think we're trying to say that we need to really look at how do we progress and get the board in the very best place for progressing the work. And just to go through, I won't say anything around the noting the progress we've made on the other things. We're giving you the heads up that there is this operating model coming. We are working, we will do what we can to help get us in the best place to deliver on that. We do need some support at board level. We need support that we need to be reporting into the board routinely. We need to look at the risks for people and culture being really embedded within the board risks. We need to be able to have the right support. I know Sonali talked about money, and we know how compromised we are, but really having committed resources, if it's people that time is committed. We don't have, all of us here are here because our organisations are giving us time to do this. There is no specific resource independently of this, and that's been a real challenge for some time, because it's not consistent, it's not protected, and it's a real priority. So anyway, I'll leave it there then.
So colleagues, that was hugely rich and impressive in its breadth and depth, and it struck me that it was one of those things that we could do. It would do justice to a whole development morning in terms of getting underneath some of it, because the more you get underneath, there's more that is going on. We've got four hands up actually, and we're running out of time. So I'm going to make a final executive decision that I'm going to for the next two items, they're for noting rather than for expression. And I think the City ICP paper is a really good one, and I think perhaps that should be put up for a discussion, a longer session next time. So we'll just finish off this discussion because we've got 5 people who want to make a contribution, and we'll note the ICP board papers, schedule the discussion for the city bit next time, particularly because Q was going to do a bit of a presentation, and then note the performance and strategy stuff. So we'll take these 5 contributions all in one go, and unless there's something really pressing on the other 2 papers that people want to raise, we'll close the meeting after that. So Michael Williams.
Yeah, a really thought-provoking presentation, and thank you to the whole team for putting it together. In the year that I've been on the ICS board, I think this is the first time we've had some dedicated time to talk about workforce. So I really welcome that, and I think your suggestion, David, is a good one about some further dedicated time as part of a development session. I suppose I wanted to sort of alight on a particular area, which was the question about culture change, which features very strongly in here. It was something that we were discussing last night at the ICP board in relation to the culture change that was necessary in relation to the work we were doing at a local level on rough sleepers, and the permission that people need from their leaders, their managers, to work in a more collaborative and different way. I suppose outside circumstances such as COVID and the vaccination program have forced that level of collaboration. It's been willingly given. I try to imagine what that collaboration would be like if it were focused on the health inequality issues that the whole system faces, and the cultural change that we were looking to achieve was that focus on the health needs of our population, and we were mobilizing our resources to meet them and giving our staff permission to be looking beyond their organizations. At the moment, a lot of what is done, how we're measured, performance is measured, and so on, is by individual organization. But we all know that increasingly it's the way the system works collaboratively that is going to make the difference. So let's not underestimate that culture change, and let's grasp the challenge that the team are presenting to us about our providing the leadership at ICS board and through our individual boards for the cultural change that needs to happen. Thank you.
Okay, thank you. And then Paul Devlin.
Thanks very much, David. Paul Devlin, Chair of Nottinghamshire Healthcare NHS Foundation Trust. I've got a little bit of an assurance quandary going on following on from that big presentation. So as we were working through, I was feeling more and more assured about the NHS integrated work around people. But as we progressed, less and less assured from an ICS perspective that we are capitalising on and integrating with the workforce challenges that our local authority colleagues and third sector colleagues also have. And given that right at the top of the meeting, we were talking about some real challenges where we were saying it goes far beyond health and social care itself. This is about actually the social challenges that we face across Nottingham and Nottinghamshire. I guess the question I'd put to Lynn is, how are we getting assurance that these really strong pieces of NHS work are actually dovetailing with what our colleagues in other parts of other partners within the ICS are, I'm sure, similarly battling with and having challenges with? Because if we're not integrating those together, we get into that risk of almost being in competition with one another around people, but also not capitalizing on actually how we can work together for our whole community. So that's a bit of a puzzle for me, and I don't know if that can be unpicked at all. Thanks, David.
Yeah, thank you. Can I bring the others in, oh, yeah, sure. Lynn? And that, yeah, sorry, yeah, because otherwise, Mel Barrett.
Thank you, David. So, colleagues, I'll just introduce myself formally. So, Mel Barrett, Chief Executive of Nottingham City Council. Thank you for that comprehensive presentation, and clearly a number of the themes overlap. And I applaud the work that's being done. Just a couple of observations from me. So my reflection is that I'm also interested in top level buy-in of each respective organisation in terms of where the chief executives are and those with decision-making authority to back such initiatives. Before coming to Nottingham, I found myself as a local authority chief executive one of less than 3% of local authority chief executives from a Black, Asian or minority ethnic background. And across health and local government, it's less than 2% of chief executives that are either Black, Asian or minority ethnic. And therefore, in terms of Nottingham, having a Black, Asian or minority ethnic population that was 35% BAME, that was an attractor for me coming into this role. And I think it's really, really important that people and citizens can recognise themselves in the leadership of the organisations that serve them. So I'm interested in the work that's being done in terms of that leadership piece, in terms of top level buy-in. And as part of that, in addition to the good work that's being identified, what are the outcomes that we're seeking, and what will be the metrics that we measure to measure our progress on that? I think the other thing I'd say is that outside of health and local government, a lot of organisations are paying serious attention to this issue. So please don't ignore what's being done in terms of some areas of business and some areas of other public sector organisations that are of the view that this is to be tackled seriously with top level effort. And if there's anything I can do to support you in this, please don't hesitate to engage me. Thank you.
Okay, thank you very much, Mel. Rosa Waddingham.
Thank you, David. Rosa Waddingham, Chief Nurse for the ICS and the CCG. A couple of points, building somewhat on what Paul said before. So we talked about the workforce, and the presentation started off with a couple of examples of where health has done developed initiatives to reach out into social care nursing. I think I'd be really keen to see, as that structure develops, a much more inclusive way to bring in health and care workers who aren't part of the NHS, knowing that over the last year we found that that's a group of people who can often feel very isolated from the changes that are happening. Secondly, as Mel has said, the work around the racial equality steering group and the work that Sonali described is just really impressive. But we know that people who are at the intersectionality of discrimination, and so, for example, young Black men who are gay with mental health issues in our city, we have research that shows they are perhaps our most discriminated against groups. So I would hope that we can also see some of those racial equality steering groups linking to our disability and wellbeing networks, our LGBTQ+ networks, so we can really understand the impacts of the intersectionality of discrimination locally. And then finally, Lynn, I absolutely support the things that you've put as an ask. But what I would suggest is that when we talk about risks and those workforce risks, we perhaps need to frame them not only in the risks to our workforce and plan, but in that wider risk of system impact on delivery. So those workforce issues that you've talked about will have an impact in our ability to achieve and deliver the plans that we have. And it would be useful to see some really clear linkage between those two things in the articulation of risk.
Okay, thank you, Rosa. Richard, and then Adele. And if we could keep them fairly pithy contributions, I'd be very grateful. Thank you.
I'll do my best, David. So 3 points from me. The first one, Lynn, you spoke about the scale of the work. That's absolutely clear. What I'm really keen, though, is us to identify whether through the lived experience of our workforce, we can actually measure a quantifiable impact from the work that we're doing at the moment. In the NHS world, we have the National Staff Survey for 2020 that goes, we get the information on the 11th of March. I think that's a powerful lens we can look at. But as Paul was saying, we also clearly need to be viewing it through the lens of care organisations, voluntary sector, etc. So how do we measure the success of this? The second bit is Claire was talking about paying attention to health and well-being. We touched earlier on the agenda about the importance of finding that balance between COVID, non-COVID services, but also the welfare and well-being of colleagues. And I think we need to shape that thought around our decision making for the next year. And then Lynn, obviously, you've delivered a huge amount. I think we're all aware that you're stepping down in June. I think this piece of work is central and one of the most important things we're doing. So we need to begin early conversations about proper succession planning so that when you leave, the work doesn't stop.
Thank you, Richard. Adele, were you wanting to come in? Adele, yes,
yeah,
you were.
please. Yeah, thank you. Thanks. It's really good presentation, and a lot of challenges in there for us all to pick up and address. I think I just wanted to make some points around who is coming into our workforce and what we do to support that. I think the Care for Nots development is really positive. I think in the next few years, our integrated teams working alongside each other, if we do this right in neighbourhoods, will be really important to sort of making visible the range of careers and pathways open to people moving into this workforce, and that will have tremendous benefits for people in the care workforce who might want to progress within that, or in sort of adjacent areas in health, and also in terms of just bringing people in, because it will be seen. Social care will be seen as a thing that has a progression within it and a progression into other professions. So I think it's really important that we show those opportunities, and also that we smooth and reveal those pathways. And I hope that as we move forward, we can work together to develop that Care for Nots platform to make that very clear. I'd love to have a chat about that at some point, actually. I think it's, if you look at a city like Nottingham, where people, we've got a diverse population, and we've got areas of really significant deprivation, and we've got also relatively low access to higher education, which is potentially a barrier to some of these professions. So it makes all of this work really important about, revealing and showing how to get into the whole health and social care working environment. And I think it's incredibly important that we get people into all areas of practice and in leadership who have lived the sorts of challenges that people live in our city. And that is I think Rosa's right to pick up that intersectionality point. It would be, I think it's really important for Nottingham that people locally are getting these good jobs that lead somewhere, and where hopefully they will find that we're decent and inclusive employers, as you know, if this work moves on, as we will all support it to do, I'm sure. And you know, it's really important that people are getting those local people are getting those jobs and being supported to move into these professions. It's important for them themselves. It's important for people who, as been flagged earlier, will need our services. It's really important that our services reflect the people they serve.
Thank you very much, Adele. Mel, is that a legacy hand that you got there?
Yeah, sorry, John.
Yeah,
David, that's a legacy hand. I'll take it down.
No problem. I just didn't want to make sure. So I think what this conversation has shown us is that there's a lot of interest of the board in this, and rightly so, because the workforce is absolutely critical. There are also interfaces with issues of equality and diversity, and making sure that there are equal chances and equal opportunities for all, and people are supported right across the spectrum of need and across our whole population. And I still have the same observation that I had at the beginning of this discussion, which is to leave. It's impertinent, isn't it, as the outgoing chair, to leave a job to consider whether there should be a development session when you're not going to be here. But I do think that's my sort of outgoing recommendation, because I think it's very difficult to do this. Being very difficult to do this justice, even though we've overrun. But I'll hand back for the last couple of sentences, Lynn, to you. But I do want to applaud the work that is going on. And actually, the thing about this is that the high-level presentation belies the work that's clearly going on underneath, and that's the assurance question, that I think it's difficult to navigate something like this without going into a bit more depth. Anyway, Lynn.
Okay, thank you, David. And just to say that I think the comments and the feedback are really positive. I think it's down to us as a system. I think the message overall is we're responding to an NHS people plan. We as a system don't want to just do that. We want to look at it as a whole. To do it, we will need to have good data systems, organisations supporting and being open with their workforce data for us to be able to do that. Workforce metrics will be given to us by region, but also we need to look internally about what are important to us around our priority areas, and they are reported and assured routinely and regularly as part of this board, and the board oversee it and actually make sure that this is as equally as important as finance and other priorities in our system. So really welcome the comments, and we'll continue to work really hard on getting us to the next level and being on the front foot.
Thank you very much, Lynn. The other point I wanted to pick up on the actions and recommendations was the point about a non-exec lead into the programme. And Eric has made the point that this ought to be perhaps taken offline, and he's made the point that Kathy has just started, and there will be a whole issue about the roles of non-execs, elected members in this. So I think with your agreement, Kathy, we'll leave that one with you as well to work through with the NEDs. So I'm going to note the other two items, and obviously for the next agenda, people will plan according to sort of perhaps giving those a higher profile, but otherwise call the meeting to a close and suggest